This clinical trial has started about 3-4 years ago, and the main endpoint or the main goal of this individualized way of dosing of ATG was to see how we can expedite immune reconstitution after stem cell transplantation. And why? Because what we showed before is that ATG, when given in a standardized weight-based dosing, the pharmacokinetic or the clearance of the ATG was highly variable. And the highly variable ATG was related to a highly variable immune reconstitution after transplant. By individualizing the ATG dosing in this clinical trial called, let's say, Parachute, the goal was to have a very low ATG exposure after transplant to make sure that the immune reconstitution was good after the allotransplantation. The clinical trial was powered for the endpoint CD4 reconstitution because we showed before that CD4 reconstitution was a great predictor for outcomes in terms of non-relapse mortality and relapse. What we found in this clinical trial was that by individualizing ATG, not only weight-based dosing, but also absolute lymphocyte-based, let's say, dosing, plus giving the ATG day -9 instead of day -5, we found that the CD4 reconstitution was way better compared to the historical way of dosing. Almost 90% of the patients achieved CD4 reconstitution by day 100, with the individualized way of dosing done in this clinical trial called Parachute, compared to only 50% of patients who achieved CD4 reconstitution by day 100, using the old way, historical way of dosing, weight-based, dosed from day -5. Although not powered for the endpoint overall survival, the outcomes show that it was close to be significant in this, let's say, comparison between the historical way of dosing to the individualized way of, let's say, dosing. In summary, by individualizing ATG dosing using the Parachute nomogram, weight-based and absolute lymphocyte-based dosing, the immune reconstitution is better and faster, resulting in better survival chances for the patients who got this individualized way of ATG dosing.